Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. Today's podcast is about atherosclerotic cardiovascular disease with a focus on cardiovascular outcomes, data for GLP-1 receptor agonist-based therapies, DPP-4 inhibitors, and SGLT2 inhibitors. Let's start with GLP-1 receptor agonist-based therapies. 3 available GLP-1 receptor agonist-based therapies have been shown in randomized controlled trials to significantly lower the risk of composite 3-point MACE in individuals at high risk for cardiovascular disease. These include liraglutide, semaglutide, both injection and oral, and dulaglutide. 3-point MACE includes 3 major adverse cardiovascular events: non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. Now let's look at the meta-analysis data for GLP-1 receptor agonist cardiovascular outcomes. A 2025 meta-analysis of GLP-1 receptor agonist cardiovascular outcome trials found a 14% risk reduction in MACE. This benefit was seen in individuals with or without established atherosclerotic cardiovascular disease. The benefit also occurred regardless of A1C and regardless of background glucose-lowering therapy. Another meta-analysis reported a 21% reduction in MACE risk. The effect was consistent whether participants were receiving SGLT2 inhibitors at baseline or were not receiving SGLT2 inhibitors at baseline. This is clinically important because a person who is already taking an SGLT2 inhibitor, for example, for heart failure or chronic kidney disease, may still derive atherosclerotic cardiovascular disease risk reduction benefit from the addition of a GLP-1 receptor agonist. Now let's talk about FDA indications for MACE reduction. Only dulaglutide and oral semaglutide have an FDA indication to reduce the risk of MACE for primary prevention in adults at high risk for cardiovascular disease. For dulaglutide, this is based on the REWIND trial. For oral semaglutide, this is based on the SOUL trial. Liraglutide and semaglutide injection are approved by the FDA for secondary prevention in individuals with established cardiovascular disease. The approved populations include liraglutide in individuals with established cardiovascular disease and type 2 diabetes, and semaglutide injection in individuals with established cardiovascular disease and those who are overweight or obese. Now let's move to tirzepatide cardiovascular outcomes. The SURPASS trial compared tirzepatide with dulaglutide. Tirzepatide was non-inferior to dulaglutide for time to first MACE event and was superior to dulaglutide for time to all-cause death. Now let's briefly cover DPP-4 inhibitors and MACE. Randomized controlled trials, pooled analyses, and meta-analyses evaluating DPP-4 inhibitors have repeatedly shown that this incretin therapy class is cardiovascularly safe but neutral for MACE reduction. In other words, DPP-4 inhibitors do not appear to increase cardiovascular risk, but they also do not reduce MACE. Now let's turn to SGLT2 inhibitors and cardiovascular outcomes. SGLT2 inhibitors have been convincingly shown to lower the risk of hospitalization for heart failure and improve renal outcomes. However, evidence for benefit on 3-point MACE has only been shown for select agents, and the impact on MACE is less than what has been seen with GLP-1 receptor agonists with proven cardiovascular benefit. The characteristics of the high-risk primary prevention population were not consistent across all SGLT2 inhibitor trials. In general, these high-risk primary prevention populations included features such as age 55 years or older, albuminuria or proteinuria, hypertension with left ventricular hypertrophy, left ventricular systolic dysfunction, left ventricular diastolic dysfunction, and an ankle brachial index less than 0.9. In individuals with type 2 diabetes and atherosclerotic cardiovascular disease, empagliflozin decreased 3-point MACE compared with placebo. Canagliflozin also decreased 3-point MACE compared with placebo. Dapagliflozin had neutral results for 3-point MACE. Therefore, when adults with type 2 diabetes have established atherosclerotic cardiovascular disease or are at high risk for atherosclerotic cardiovascular disease, a GLP-1 receptor agonist with proven cardiovascular benefit should be initiated as first-line therapy, independent of A1C goal or other glucose-lowering treatments, including metformin. Remember, the meds reducing MACE are semaglutide, liraglutide, and dulaglutide. As an alternative to a GLP-1 receptor agonist, with consideration of comorbidities, potential side effects, and individual preferences, clinicians may initiate an SGLT2 inhibitor with cardiovascular benefit, canagliflozin or empagliflozin, to reduce major adverse cardiovascular events in adults with type 2 diabetes and established atherosclerotic cardiovascular disease. For adults with type 2 diabetes and established atherosclerotic cardiovascular disease, or at high risk for atherosclerotic cardiovascular disease, the use of an SGLT2 inhibitor reduces the risk of hospitalization for heart failure, regardless of background glucose-lowering therapy, cardiovascular therapy, or A1C. In adults with heart failure and/or chronic kidney disease, an SGLT2 inhibitor should be initiated as first-line therapy. To wrap up, when our patient has type 2 diabetes and established atherosclerotic cardiovascular disease, we choose medications with proven cardiovascular outcome data among the GLP-1 receptor agonists. Semaglutide, liraglutide, and dulaglutide have demonstrated major adverse cardiovascular event reduction and carry FDA cardiovascular indications, while among the SGLT2 inhibitors, empagliflozin and canagliflozin have the strongest evidence for reducing major adverse cardiovascular events, with dapagliflozin showing particularly strong benefits for heart failure outcomes. Tirzepatide is an exciting addition to the field, and the SURPASS trial demonstrated that it was non-inferior to dulaglutide for cardiovascular outcomes, strongly suggesting cardioprotection, although it does not yet have an FDA indication for major adverse cardiovascular event reduction. As always, match the therapy to the patient's cardiovascular, kidney, and heart failure profile, and remember that the best diabetes medication is often the one that improves both glycemic control and long-term cardiovascular outcomes. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.